The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk.
What were the factors that led you getting out of the profession?
And I also wanted to leave because I found I was in quite an anti-intellectual environment, right? So I like critical thinking. I like questioning everything. Like if someone says we do it this way and I go, why? Because we've always done it that way. And I go, well, that sounds like maybe something we could question. People just did not want to think about it. A lot of people, that I was involved with. And I'm not talking so much about students as about my colleagues and about other people I was involved in the academic setting. There was a desire to have authority. We didn't want to lift the profession up, but there wasn't a desire to really question their underlying beliefs and practices, and they weren't prepared to change.
Welcome to the Success in Practice podcast. Today, I'm joined by Nic Lucas. Nic is an entrepreneur with a background in neuroscience, medical research, and consulting. He has 5 degrees, including a Doctor of Philosophy, PhD. My first encounter with Nic was when he taught me neuroscience at University of Western Sydney back in 2001. I still have the neuroscience textbook, the workbook that he wrote for us and he put together for us in my clinic that I still refer to. He ran a publishing business and was the editor of the International Journal of Osteopathic Medicine. He's married with 2 children and now resides in Sydney. As a high schooler, he moved 9 times in 11 years, crediting this experience as shaping his regard for authority as being earned and not freely given. It was here that he learned to make friends quickly and get things done. He grew up in a conservative Christian home with a minister for a father. Whilst describing his family's belief as extreme, he always felt loved and supported growing up. He began studying osteopathy at RMIT and completed his studies at Victoria University. He has a master's in pain medicine and a PhD in diagnostic medicine. He practiced as an osteopath and then sold his 2 practices and got out of that profession in 2009. He now works as an advisor and as a consultant to business people who feel stuck in their thinking. And he also understands a thing or two about high-ticket sales, to say the least. He has started numerous online businesses and tackled the trenches and the technical aspects of starting, building, and scaling businesses. He continues to be involved in some of those projects whilst working with his business clients. Nic, welcome to the Success in Practice podcast. Mate, a big part of me is very glad that you're here, whilst a small part of me is very anxious, wondering what you think I could be doing a lot better right now. But hopefully this kind of goes well. Thank you for being here. I know it's late and you're giving your time, so I appreciate that, mate.
That's my pleasure. Happy to be here.
Mate, look, I've had some mostly osteopaths on this podcast so far. And I don't think you're I'm not sure. I don't think you're no longer registered as an osteopath, are you? No.
I'm not, no.
So I think the best value we can give to people today is to really explore your views around mindset, sales, and maybe the concept of getting unstuck. You do have a research background, and so getting your input on the research landscape would be good. And I'd really kick myself if we didn't talk a little bit about osteopathy. I want to look at your personal journey and chat with you about your own development. We can learn what some of the fundamentals of success look like there in real life and just looking at your growth as well. I want to look at the micro and macro aspect of starting, running a business's success, failure in multiple businesses and how we can learn from all that. And so, yeah, that's where I want to go. It's a lot there, but if we get through it, we get through it. If we don't, we can always do part 2, I guess. Look, in terms of osteopathy, you're on the outside looking in with an insider's perspective. You've been there and done that. And so I think your input here can be valuable to a lot of the osteopaths and healthcare practitioners that are listening. So I'll get straight into it. I'll get to the business side of things. But first things first, I want to talk a little bit about Nic growing up. You moved around a lot. That affected your perception of authority. Tell us how that played out for you, and talk to us about authority and what that means and how to best earn it.
Yeah, well, I guess the comment would be, because I was plucked out of school after school after school, and I was just, put down in front of another teacher, they became a blur. And so I always had someone telling me what to do with some rules they had to do, and a lot of those rules were arbitrary, or they seemed stupid to me or silly. And so instead of growing up in one spot and having this kind of authoritative teacher or even group of teachers who you kind of grew up with and you always saw them, that just got dismantled for me entirely. And so I just found that I wasn't prepared to give respect to anyone just because they were in a position of authority. And so that really kind of set the scene moving forward right through into, I think looking back, even to my willingness to go try new things and stand up against authority and speak up, when I thought something could be done better, or if something was being done poorly, no problem speaking up and confronting that, because I didn't have that fear of that authority. So I think that's probably, the main thing that shaped.
And talk to us a little bit about authority. It's one of the things that I discuss a lot with some of maybe the younger practitioners that I see. And how do you best earn authority? Like, in your view, when you've talked to a lot of people, especially the clients that you work with, they're usually very, highly successful people who have a lot of responsibility, and they need to use and wield authority. How are you finding, what's the best way of earning that authority? How do you get it?
I think it can be summed up very simply by saying lead by example, right? So especially in the world I'm at now, and we all are in this day and age, it's very easy to manufacture authority. And when you look at what influences people, all the trappings of authority will influence people, because we have these heuristics. There's these mental shortcuts where we defer to people, like wearing a stethoscope or having the title doctor, or all those kinds of things. They imbue someone with authority so that people then do what they say, but all of that's fake. Real authority is meritorious, it's skill-based, and it's leading by example. So it's carving the way forward and being able to do what it is that you are leading people to do. And for me, at least, they're the people I look to with having authority. There's the other type of authority, which is might equals right, which is like I'm more powerful and I can therefore assert my authority on you. But that, to me, is completely unethical authority. So I'm much more for the lead by example, prove what you can do by doing it, and then you'll get authority that at least I respond to.
I was listening to a podcast the other day about chimpanzees, and when a chimpanzee takes over with that might is right mentality, he ends up getting ripped apart by the other chimpanzees eventually. They literally rip their arms and legs off, and so that won't last very long. And so what I'm getting from what you said is really, you're looking at results. People that get results often get authority. Would that be correct to sum it up that way?
Yeah. And my observation would be that some people are just far more prepared to get results and to do what it takes to get results. Yes. A lot of others aren't prepared to do that, and there's no value judgment around that. But there's a certain type of person who's prepared to be relentless in that pursuit of knowledge, expertise, skill set, always learning, always improving. It's interesting even thinking about evidence-based medicine, because, see, I grew up in the decade where evidence-based medicine became a thing. So it was in the 90s, right? And so it's when it became a term. The first book came out about how to practice EBM, and I loved it. I got right in with it, and was, I guess, I didn't know so much at the time, was quite instrumental, though, in bringing that whole language into the field of osteopathy through the journal that I founded with a really good friend of mine, Rob Moran, right? And he was an incredible partner to work with on that project. But even with that, one of the reasons I did a clinical epidemiology or evidence-based medicine degree was I thought to myself, if I'm going to embrace this approach to practicing healthcare, I need to critique the shit out of it. I'm not going to accept it simply because there's some authority saying evidence-based medicine is the best way forward. So that's why I did the degree in it, so I could critique it and understand its weaknesses and limitations, as opposed to just accepting it without critical thinking. And so what I've come to understand too with that evidence-based practice is mediocre practice, which is a controversial thing to say because they call it best practice. but it's mediocre by the very fact that it's the average best results they can get in randomized clinical controlled trials. And that's great. It lifts the whole, practice if we can know, okay, this is what we should be doing, but then it's just the average results we could expect. How does an individual practitioner decide to go even further and get even better results than you would get by just practicing best practice? So that's the way, at least I see it. I call best practice average practice, and you want, someone who's going to take it further, and that's the kind of person that would get authority because they're still pioneering, they're still leading.
So would it be correct then to say that the people that are obviously practicing in that fashion, let's call it average practice, how do they take the next step, or what have you found that are they doing things that aren't evidence-based to take the next step? Are they is everything that's kind of being pioneered not evidence-based?
Yeah, and I wrote an editorial about this, and the mistake of thinking that evidence-based practice is evidence-only practice. And that's what people do. And I've come across many medical professionals in my career, not for a while because I've been out of it, but who tend to just really fall into that trap of it has to be level 1 evidence, otherwise it doesn't matter. And that's just banal. It's non-critical thinking, because there's so many areas of medicine where there literally isn't enough cases to ever get level 1 evidence at all. And so you have to base it on the best available evidence that you have, combined with, your critical thinking skills and what the preferences of the patients are. That's what it is. And so you do your best as you can to practice according to the evidence. But when the evidence can't take you any further, that's when your knowledge, your curiosity, and your willingness to experiment a bit, and being completely forthright with the patient about that being the case, that is where you begin to pioneer and begin to notice different things. I mean, just one example of this, right, is that everyone learns orthopedic tests. I taught orthopedic tests, right, at UWS. And so you learn the textbook way to do it, and you get assessed on the textbook way to do it. And I had so many examples in practice of where I would get those tests. And the key thing there was trying to reproduce a patient's pain, for example. And they'd been told that nothing wrong with their knee, and they'd had all the tests done. Well, how come when I did the test, I was able to reproduce their pain? Right, when other people had done the same test? It's because I maybe tried the test in a different position. Mm-hmm. I tried to do it in a way that was functional. So instead of having them on a bench, lying on their back and wiggling their knee about, which they never ever do in their entire life, actually get them into the position they're in when they're actually feeling the pain in real life and doing the test in that position. And then, hey, presto, you go, yep, I've just reproduced the pain. And so that's an example of going, okay, well, the evidence-based thing is to do the test this way, and I know to do it that way, and I've done it that way, and I didn't get an answer. So what am I going to do to be creative and curious here, to work with this person to try and find out what I'm really after, which in this case would be pain reproduction. So that's just one example, I think.
Great example. And I think that's great insight for all the practitioners, young practitioners especially, but even experienced practitioners, is that the evidence can kind of point us in a direction, and I guess experience can take you further if I think you're also being critical of yourself as well. I mean, you can't just keep repeating the same things over and over again. You're going to get a patient that doesn't present in the same way, and you might have to use that knee test that you talked about in a different position. And so that's a great tip from somebody who's not been practicing for a while. Thank you, Nic. Mate, early in your adult life, you faced some struggles with anxiety. I think you've been quite public about that. You even went on TV. And at that time, you yourself had a young family. What was that time like for you, and what were some of the shifts that you had to make to turn that situation around?
Yeah, so that was a very tough. I mean, that's there was when I was born. In terms of when I look at defining moments, there was when I was born, right? And then there was when I had 4 years of anxiety and panic attacks, and the reason that happened. And that became a very defining point of my life. It actually happened at the end of my undergraduate, just before I went into the master's degree of osteopathy. And so I was housebound for a while. I mean, I got so anxious that I couldn't even call up to pay a phone bill, like just speaking to someone, right? And all of it completely illogical. And that's the other thing that goes on with anxiety, is your brain is saying, and you're saying to yourself, why is this happening? It's not like you're literally scared of the person you're going to speak to, but nevertheless, your body still has this entire reaction. So that was a really tough time. And part of the reason for that too was I was unprepared to speak to people, professionals, about it because I didn't trust them. Right. I didn't trust them to confuse me even further with what I was going through at the time. And so I just had to battle through with it. And there were some dark times, and I've talked about it before. I mean, you know, the easiest way out of a situation like that is to end it all, not because you necessarily want to kill yourself, but because it's just, you want the current problem to stop and to end and to have some peace. So that was what I went through. And I gave lectures at Western Sydney having panic attacks. Yeah. And, you know, here I was going through every nerve in the body or something like that with a big crowd of people watching on. And I don't think anyone had a clue that I was going through that right inside. No. But that's what would happen. You did a great job. We couldn't tell. Yes, right. And I think that's the point, and that's why I wrote the book too. Much later on, when I'd managed to get through it and understood myself a lot more, was I couldn't find any good books in a bookstore that provided an evidence-based way to deal with anxiety. A lot of them were talking about depression, and I thought to myself, well, there isn't one out there, so I'm going to write one on it. And the other reason too was I was working in the city at the time, and I had a lot of quite senior banking, CEOs and execs who were patients, and they would describe the same thing. In fact, I could kind of tell that they were maybe going through anxiety, and I'd make some joke about myself having gone through anxiety. And so often they would then confide in me that they had that, and I was the first person they ever told about that they had this. One guy used to have to take 4 shirts to work because he'd sit in meetings, no one would know, and he'd sweat right through them from panic attacks and have to go and change his shirts. Wow. And so it just clued me onto, the internet came around, and it made me just realize, hang on, if I can provide a resource so people don't even need to go into a bookshop and take an anxiety book to the counter and kind of advertise the fact that they're dealing with this issue. And so that's kind of why I did that. But, all the different mental frameworks I had to go through would probably take too long to dive into. But I did. Probably if I sum it up, I had to ultimately confront the fear that was ultimately driving that anxiety, and come to a place of absolute acceptance around what was going on. And once that happened, things completely began to settle down. And that really did send me on a different path after that. Well, I don't really want to go into the details of it, but just speaking about that fear, did you confront that fear in small doses and then gradually increase, or did you just face it head on all at once? There was 2 kind of defining moments. I used to have panic attacks. And so then if you had a panic attack, you would have what they call anticipatory anxiety. That means if you're out in public, you get scared that you may have a panic attack in public. And so therefore, that's why you don't go out in public. And I remember just getting so angry one night at this panic that I kind of joke because it sounds kind of silly, but you know, when in that first Rocky movie, he's kind of been punched in the head and then he just says, "Come on, hit me." Yeah. And I wasn't trying to mimic Rocky, but I kind of said to this panic attack, you know, if I can take me down or fuck off, you know, to excuse the French. But and really, I never had a panic attack after I faced it that way. Yeah. So that was that. But then I still had this kind of ongoing anxiety around this kind of core fear, and no, eventually I had to come to terms with and accept that fear. And it was that one kind of moment. And that was after that moment, it was probably about 3 years later, that everything dissipated. So for me, at least, it's more complicated than that, right? So, but for me, at least, those were the 2 kind of key points, was coming to acceptance. Okay. That time where you wrote the book, that coincided, I think, with your early career as an osteopath. Is that correct? No. So I I went into practice in 2000 and I wrote the book in 2009. So it was like almost 10 years after I'd been kind of got past it. Were you still struggling with that whilst you were an early graduate? Yeah. Right. Because I was lecturing, I was in practice. Yeah. Right. Okay. And so how did you feel about the work you were doing at the time? Did the anxiety play a part in that? Was that something that affected your work? Did you have to kind of put it aside whilst you were treating patients? I just had to put it aside. Yeah. In the same way that I had to give lectures and do all that sort of stuff. It was just something that I dealt with and then had to put aside, and it was literally sheer willpower that just kept me going.
Tell me about that time as a osteopath back in the day. What did you enjoy about it? You know, what didn't you enjoy about it, and what ultimately were the factors that led you to getting out of that profession?
Oh gosh. The reason I got into osteopathy was because, well, like almost every osteopath I know, is because they had some kind of experience that was beneficial to them, and they've gone, right, I want to do this for other people, right? And so that kind of got me into it. But within a year, I was struggling, thinking, I'm not sure how long I'm going to last in this profession. And there's a couple of reasons why. One, I really, really disliked being ruled by an appointment book. Right. So every,
Me too.
yeah. Right.
Hate
So I didn't enjoy that. And I thought, really, I mean, it'd think pretty obvious. Isn't that something that you would come up with? But even in clinic, when I was going through clinic at uni, the fact that there was these time slots I had to go and it was one after the other, I just began to go, oh, I'm not sure I'm going to kind of jive with this for very long. The other thing I didn't enjoy about it was again, because I was ready to push the boundaries. And so I continued to do a ton of professional development. I mean, I did a lot of other courses. I went to the US and I studied with musculoskeletal physiotherapists, and I went to study with orthopedic doctors, just to, again, increase my skill set and get different ways of thinking about it that expanded what I could do. And often people in Australia, at least, came to osteopaths with a preset idea of what to expect. And as a young practitioner, I often felt like I had to cave into their expectations of what I was going to do. Now, by the end of being in practice, the first consultation often went like this. Okay, take a history. I say, well, look, I'm actually not going to treat you today at all, because I need to get to the bottom of understanding exactly why you're in this pain. And you've been to that person and that person and that person, and you got treated the first time, right? They cracked you, they rolled you, they MET'd you, they pulled your leg or whatever it is. Are you better? No, I'm not. So I could do that, or we could actually try and understand it. So I'm going to spend most of the time assessing you so I can understand what the treatment plan is, and then we'll start treatment plan when I actually know what to do. And I had absolutely zero qualms about saying that. And if they said they wanted to be manipulated, I'd say, well, I don't do that, but I can refer you to someone down the road who does. Right? If that's what you want to do. So there was a shift and I guess a maturity and a confidence that came around, also knowing that I can best help people by helping them the way I know how to work. And as far as I could tell at that time, I was practicing the most evidence-based I could practice, in addition to taking it further. So there were the things I didn't like about it so much.
Let me just ask a question on that before I let you continue, because this is interesting, I think, for people to listen to. I've heard you talk about previously that you know, patients are really interested in an outcome. Clients, forget patients. When someone's buying something, they're really interested in what that's going to do for them, and so they're interested in the outcome. Whereas you, as a clinician or as a practitioner, you have a process. And so you've just described then what you've said to me is you have a process to really get to the bottom of what people of the pain that they're experiencing. And yet they wanted it, they're looking for something else. They're looking for an outcome. And so did you find that you had to learn that the hard way in terms of losing patients? And, you know, because they wanted a certain outcome and they felt like they weren't getting it. Now, whether they were going to get it eventually, that obviously they were going to get it with you eventually, had they followed your process. How do you reconcile that? How do you kind of reconcile those things in terms of giving the patient the outcome that they want, versus you having to put that process in place to actually give them the outcome?
So I guess the best way you might describe how I ended up thinking, and I'm not sure if they still refer to it this way, they might describe it in different terms, right? But call it a pain mechanisms approach to diagnosis. So what I gathered from all of the diagnostic tests that you could ever learn is that they're virtually all unreliable, and that's what my PhD was in. And if they're not reliable, they're not valid. So they're very often not even measuring the thing that you think they're measuring. But when you did the tests, or when they were studied for reliability, the thing that came out as having acceptable reliability was pain reproduction. Now, that required a shift in thinking, because a lot of the time in osteopathy, the whole thing is, I don't chase the pain. You've got to try and identify these other things in the body. And yet every time I looked at the research, the people who even were the experts couldn't reliably identify those other things in the body. And so I found, like, I'm going, okay, do I want to spend my life chasing this enigma, or do I want to at least try to experiment with trying to identify what's going on with the pain. And so that's why I went deep into pain and ended up doing a full master's degree in pain medicine and began to apply that. So what would happen is, if you've got someone who's already been to 2 or 3, 4 people, and they've been told they can't find anything wrong with the knee, but then they've been given all these treatments that are just like really throwing shit up against a wall to see what works. And you come in and you say, well, I'm not going to treat you, right? And often that's the kind of person I would get. It wouldn't be often the first practitioner. I always found that they wanted someone who took the time to really understand what was going on. Now, like that example with the knee, when I was able to reproduce that pain with the person in the functional position they were in, it was like a hallelujah moment. I don't know what better outcome that person could have got other than, oh my God, this person has been able to, yes, that's it. And you know, that's what people respond when, right? And from that, we were then able to understand what was going on and what they were doing in their daily life to contribute to that pain. And so I sent them away with homework to say, you know, I want you to notice I hope you get pain this week, because when you do, I want you to notice what you are doing, because we've shown you if you modify it, the pain goes away.
Yeah.
And so often that was it. And people loved that. So in fact, they were getting an outcome. It wasn't necessarily pain relief or a crack or something like that in a clinic. It was a demonstration that we were on the right path.
Right.
And that would really, because everyone's going to a practitioner because they're anxious. If they weren't anxious or worried about their pain, they wouldn't show up, right? And so being able to be on the right path really quietens down their anxiety, and it's a win.
And so you really enjoyed that part of osteopathy. I mean, playing the investigator and really being able to reproduce their pain. That was enjoyable for you.
Yeah, I did, because then, especially if it led to an understanding of, most of the time it led to an understanding of what they were doing with their body in their daily life that was contributing to this problem. Mm-hmm. And then we could modify what they did, which didn't require any manual therapy at all. It required them to understand how they're using their body and to use it in a way that didn't aggravate that pain anymore. I enjoyed that a lot.
Now, I've been telling people that this is a free speech podcast. So I'm going to ask you this question. What were the factors that led you getting out of the profession? And so tell us, you know, what kind of made you go, no, this is not for me? Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you, and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
It was a range of things. On the sides I've talked about before, I was ready. I was done with the appointment book, and I wanted to have something different. I felt incredibly limited by being in a room, and I figured there was a lot more I could do in the world besides what I was doing, and so I wanted to explore my potential that way. And I also wanted to leave because I found I was in quite an anti-intellectual environment, right? So I like critical thinking. I like questioning everything. Like if someone says we do it this way and I go, why? Because we've always done it that way. And I go, well, that sounds like maybe something we could question. People just did not want to think about it. A lot of people, you know, that I was involved with. And I'm not talking so much about students as about my colleagues and about other people I was involved in the academic setting. There was a desire to have authority. We want to lift the profession up, but there wasn't a desire to really question their underlying beliefs and practices, and they weren't prepared to change. So I think all of that just led me go, you know what, I'm fighting a battle. I seem to be at odds with people because of my natural curiosity and my natural questioning, and I'm prepared to let something go. I don't care if it was been a truth for 2,000 years and we discover it doesn't work. Like, let's ditch it and move on to something else. But yeah, that combination of those things, you know, the pursuit of something different and the getting away from a stifling environment, that was the recipe.
All right, let's kind of segue into something a little bit different here. Tell me a little bit about your family. I see it because I see you on Facebook with your family, and it's very interesting. Tell me about your family. Your wife Rhoda, she's doing some great things. Your children, you know, Lara and Harley, how have they helped you level up and continue to improve? I know me as a father, the day that I had kids, that kind of just made me turbocharge everything I wanted to do. But tell us a bit about that. How have they helped you?
Well, yeah, I mean, there would be all the natural things, I guess. But the things that do come to mind are the challenges. So my son Harley, he developed epilepsy, and we've been public about that before, so that's kind of not new. And he had that when he was 5, and it was a very difficult period of time to go through when you have a child that's got a long-term condition that also you can't go get a quick fix for it. And so that was a very challenging period of time, you know, through the primary school years when we were trying to figure that out. And subsequent to that, there's been a lot of you know, follow-on things from that. And also, I got to say, during COVID, like we'd already taken my daughter out of school and we were homeschooling her for a period of time. And so by the time COVID came around, she had already been homeschooled for 2 years. But nevertheless, that was still a challenging psychological time to go through. And what I found challenging was the things that I might normally do to help sometimes didn't help. And so again, it was that I had to be able to go, hang on, I was confident in what I could do as a father to help. Sometimes it seemed to do the opposite.
Right.
And it was being able to, so in terms of how's it helped me grow, it was to step back and go, just because I know this works here, I have to be big enough to be able to go, I don't know what to do here. I have to change my approach to suit the situation.
Yeah.
And not make matters worse. And so, you know, that was a kind of quite a huge thing for me. The homeschooling thing was a great thing to do. So my daughter in early high school just wasn't gelling with high school, and she was the one who came to us with this very detailed argument about the benefits of homeschooling and how so many more kids in the city were doing it. And, you know, I couldn't disagree, right, with what she said. And because I'm in the situation to be at home, so that we could fulfill the criteria that you had to be able to tick, you know, yes, they're at home, there's going to be someone supervising them, all that kind of stuff. We were able to go ahead and do the homeschooling. So that was a really great experience that I loved doing with her. And she then went back to do HSC, and they're both at uni now, the kids, and they're awesome humans, but they're still going through the challenges of, you know, a lot of Gen Z are going through.
I see Lara's lifting some weights and she's taking after Dad. How's that going?
She's a gun. I mean, so last night she did a 5-rep max, so she did 92.5 squats, and she hit depth on every one. And so her next goal is to be able to do 100 for 5. She's done 100 for 1, but she's just absolutely persistent. At age 14, she told me, I want to lift 100 kilos. Mm-hmm. And it took her a long time to get there, with, you know, stops and starts and other issues that arose, but she got there. It's so exciting to watch that. But the squat is just, you know, it's just picking something up and heavy and sitting up and down, right? But it's just amazing to watch someone just grind through this really lengthy process of adding that weight and facing the fear of a really heavy weight, I think it carries over to life in all kinds of great ways.
100%. I think, when you put that bar on your back and you do 4 reps and you're about to do your 5th and you're not sure that you're going to get back up, and you know that it's all in your head because you've just done something that's 2.5 kilos lighter the week before. But your brain's telling you that you're not going to do it, and somehow you got to push past that.
Yep.
I think that has context around life, business, a lot of things. And so one of the critiques that I've had, especially with my profession of osteopathy, is that maybe you can help out too, because when you were going through university, we didn't really get taught rehabilitation, I think, in the best possible way. I don't know if that was your experience, and there's so much out there in terms of strength training and lifting weights and squats and deadlifts, and I think the evidence is quite clear in terms of the benefits of strength, not just musculoskeletal, but blood work and mental health, the whole lot. And so how strength training really affected you? I mean, when did you start really giving it a good go? I know you started doing CrossFit a little while ago. When did you really start, lifting heavy weights, and how's that change your life? And do you agree with my particular premise that, this should be something that all health professionals, every health professional should know how to teach a squat and a deadlift. And I think if that's at least should be in the basics, but I'll let you talk for a minute and tell us about your story with that.
Yeah, I think so I did like a strength training certificate way back at uni, and I actually kind of did a bit of like maintained a gym and was kind of like a personal trainer kind of thing in a gym in a very, very non-hands-on kind of way early on. So I'd been exposed to that early. But you get sidetracked with the osteopathy because they want you to get so overly complicated with all this minutia and really kind of fancy things that you then go, what's a squat or what's a deadlift going to do or whatever. So then you're exactly right. I got back into CrossFit and I just noticed just how much mobility I had by doing strength training. And so that was all good. And I loved CrossFit for a range of other things. It was actually my wife. So Rhoda, she had an event in her life that made her do something. She had a thyroid tumor, had to get the thyroid out. And when she and in the lead up to that, she had a whole bunch of really kind of strange symptoms. And some of those were perimenopausal symptoms that her endocrinologist, who's a female, completely missed, because she's a 30-something endocrinologist who just wasn't thinking that a woman early in her 40s is going to be having menopause symptoms, right? Mm-hmm. But a lot of them do. And so anyway, so when Rhoda was recovering at home after thyroid surgery, I walk into our office, and there's this web page up that's her entering into a fitness model competition. Mm-hmm. Or she's looking at it, right? And it's the last thing she would do. She's not that kind of person to be like an extrovert like that.
Right.
But what she wanted to do was something that shook her completely out of her status quo, and that got her and kind of forced her out of her comfort zone. So she did that and began the strength training thing that way, specifically like bodybuilding, natural bodybuilding. And she did well. She made it to world championships over in Vegas, and the whole family went over there, and she was amazing what she did. But then she switched to powerlifting because the gym she was at, there was a powerlifting coach. Anyway, long story short, she did amazing at that because she's an ectomorph, so she's a hard gainer. But still, to see her strength develop and the amount of muscle she was able to put on, she gained about 7 kilos of just pure muscle, and completely transformed her physique as a result, but also her strength. And so I've really just been following along since she started doing that. I got to hang out with her coach, and we started doing strength training. So, I'd say probably 2017 is really when I got into strength training and started to specifically improve, your typical power lifts. So bench, deadlift, and squat, and varieties of that. But I just think that the reason, like Rhoda, for example, in her program, she's got a program called Strong Woman Project, and it is aimed at that kind of late 30s to mid 50s demographic, so Generation X. And have you come across the Lift More study?
The Lift More study, I haven't, no.
Yeah. So I think this is just, I've always thought it's pretty phenomenal, and it's worth every health practitioner knowing. So, and her name completely escapes me, even though I've interviewed her a couple of times, but she's a professor up at and now I can't even remember the university. You'll have to look it up. What is it? It's not University of Queensland, maybe Griffith University up in Queensland there. But anyway, she was the first person in the world to get ethics approval to have postmenopausal lift heavy enough weights to actually create a difference in bone density.
Wow.
So up until that point, no ethics committee had given anyone permission to get women to lift heavy enough weights. So they were lifting light weights, which made no difference. And then therefore they concluded lifting weights in postmenopausal women doesn't help with osteoporosis. So they started the Lift More study, where they had women doing deadlifts, squats, and jumping pull-ups. And the jumping pull-ups were to kind of have that dynamic loading in long bones. And they were able to show in a clinical trial that not only did it slow down osteoporosis, but reversed it.
Yeah.
And that study's now been going on for, I think, 8 or 9 years, and they've continued to follow up, and they've got a clinic up in Brisbane where they do that. So the point is this whole societal bias that women aren't strong. I mean, if you look at even the characteristics of what feminine and masculine is, masculine strong, where do you find the word strong describing females? Yet their muscular potential and their ability to be strong is the same. It's just as good as males on a percentage basis, right? And so how many women could have avoided osteoporosis if health professionals had been teaching them to lift heavy enough to like the right dosage to actually create changes to muscle and bone? Because myopenia, osteopenia, they're linked together, and that can be done. So right now, every single person should be recommending for their patients to be lifting heavy weights. I mean, it's just, I can't see it. It's negligent not to.
Yeah, no, I've seen it in my clinic. We've reversed osteoporosis. I've got many cases. It's not, it's a simple process. It's not easy. It requires that they lift a heavy enough weight to make a change. And so my first question there is, why would it be unethical to have a postmenopausal woman lift a heavy weight? I don't understand.
You know, a risk of injury, fracture.
Okay, all right. Well, wouldn't that be a risk for any, or are they osteoporotic or just postmenopausal?
No, they were osteoporotic, so they wouldn't approve it.
Well, yeah, no, it's. I mean, if I had to bet money on getting a 70-year-old woman to reverse osteoporosis, and that's my mum, who I've worked with, and we've been able to do that. Many other patients in the clinic, we've been able to do that. Like I said, the process is simple. Just add 2.5 kilos a week, on the bar, and that's the only variable you change. You don't need to change reps and you just do it, and it works. It's amazing.
And it really is.
Not only the change in bone density, but just the change in them.
Yeah, changing them, functional ability, able to do stuff that they couldn't do, all that kind of stuff. It's great. So you should absolutely get the Lift More study and read up on it.
Yeah,
and see
we'll have a look at it. One of the things that I discussed with patients, and I'll say this to them, I said, look, your great grandmother never had this problem. She was usually lifting heavy things over her head and picking up really heavy things off the floor. And, our great grandparents, 200 years ago, never had this issue of having to lift the bar with a heavy weight on it. But the only way we're going to be able to reproduce that lifestyle is lifting heavy weights on a barbell. Right. And I guess that once people understand that, it takes a while for them. It's not easy to convince people to do something very hard. That's a hard thing to do. But once they do it, they never look back. Look, I want to discuss with you. You've got a solid background in research and epidemiology. Your critique of osteopathy has been around the concepts of validity and reliability. Now that you're on the outside looking in, do you see this as a critique as being just unique to osteopathy, or is it endemic to medicine in general? Especially seeing what you saw kind of through COVID and some of the research around COVID and how that was played out. Do you think that's a critique that now can be leveled out at medicine in general?
Yeah, no one's really immune to it. I mean, when one of the key papers from my PhD was that I got 7 musculoskeletal radiology specialists, right? So doctors specializing in radiology, once they finish that, then they do a musculoskeletal specialization, right? And so we had 80 MRIs, and we had 40 of them had gone for surgery. So we had arthroscopic confirmation of what at least they saw on arthroscopy.
Mm-hmm.
And they were all jumbled up, and they're given to them, and they had to do a report. They had to report on all 80 films. And so then what I had to do from all the radiologists was compile all of their findings and then go through meticulously each one and saying, well, you know, radiologist A mentioned there was a thickening of this part, and radiologist B said there was a slight tear here or whatever it was. And I had to correlate it all and see what kind of reliability they had across all of these MRIs. And of the 42 structures that they reported on, there was ACL, MCL, and collateral that were reliable, and the rest wasn't. There was no agreement between these people.
Right.
And what was really amazing to me at that point was that this is having a bit of a dig, but if I'd taken research like that to osteopaths,
yep,
I would have been some kind of heretic, and I wouldn't have gone down well. I took this, what my findings were, I took it and we sat down with the radiologists, and they were so curious and interested about why that was. I didn't get any backlash. I didn't get any kind of, well, that can't be right, and all that sort of stuff. Like, we can do it. And it was really refreshing to find just open-minded people to say, wow, because it means that every report they write in a silo. They're not giving it to their colleagues to double check or anything like that. You wonder how much of what is written on a radiology report is reliable.
Right.
And so that's just one example, I guess. Interestingly, of the number of radiology journals that I submitted the paper to, none of them thought that it was worthy of publishing. Right. So, that's the thing.
In private, they were wow curious. In public, they were maybe not so.
Well, at least the editors of the journals I submitted them to, weren't keen.
Right.
But so the point is, yes, I can't remember where it was. I think it was like in the 1999 final December issue of JAMA, I think. And it was basically this idea is that there isn't alternative health, and there isn't conservative or orthodox medicine. We're in the era now where there's either evidence-based medicine or it's not evidence-based. And so that kind of slices this whole thing around, putting little fences around osteopathy and homeopathy and chiropractic and medicine. It really says, if you're in healthcare in this day and age, the onus is on you to practice from a base of evidence. And that includes, if things have been shown not to be reliable and not to be valid, then why are you doing them? Right? Because now you're practicing evidence-based, but it's evidence that this isn't reliable or this isn't effective. And so we're in that space now where that is a requirement, at least for me, as to go and see someone in a professional setting. That's what my expectation is, and of course that's what the registration board wants and all that kind of thing. So no, it's not just osteopathy. But there's this kind of difference. Like, what was interesting was how willingly critical a lot of practitioners were, especially if you want to use the alternative medicine label, how critical they were of COVID research. But the minute you then say, I agree with you, we should apply the same standards you're applying to COVID to your practice, and all of a sudden they go away.
Yeah, right.
And so that's what I'm just looking for everyone to be honest and to go, we want to, because I think ultimately if you remove the financial requirement to, I've got to have a practice and I'm qualified in this thing and I have to do it. If you remove those things, ultimately people want to do good work. Yes. And the reason they want to do good work is they want to practice good medicine. They want to help people. And ultimately, I mean, even just talking about osteopathy, my firm belief with it and my role going into it was, we ultimately, like, the goal of osteopathy, if you were to give it a persona, was to actually improve medicine, right? Because you and I have both been in, and because we've got kids and whatnot, had to be in the standard Australian medical system, and it just leaves so much to be desired just because of bureaucracy. And so we want to improve medicine. And so how do we do that? Well, in order to improve medicine, we have to use reason, we have to use logic, we have to use good science to get there. That means that we can't, we have to do that. We have to step up to the plate and do that. We can't shy away from it. And we can't weasel our way around and go, oh, well, that's a high bar there, but we're not going to apply it to ourselves.
Yeah, look, I'll kind of take that to another level as well. You mentioned earlier about, we discussed earlier how you could, get a test that reproduces pain, but if it doesn't reproduce the pain, a good practitioner would kind of, do it in a way that would be a bit more functional, and then they could reproduce the pain. And I guess, for me, you talked about evidence-based medicine versus non-evidence-based medicine. I've always had the impression that there's good medicine. That I don't look at it as osteopathy and chiropractic and whatever. And there's good medicine and there's bad medicine. And I think being evidence informed, understand the evidence, trying to base what you do on the evidence, but then taking it to the next level and really applying your own experience, your logic, the phenomenology that you've seen in your own clinic, that you've seen patterns. I think pattern recognition is really important because it allows you to take that next step as a practitioner where you've seen things before that isn't available in the evidence, but you can say, hey, look, I've seen 1,000 of this, and I've been able to help at least 900 people. And so what kind of patterns have I picked up on, and then what can I see in this person that's in front of me? I don't think that's a bad way to practice. I think that practice is good medicine. But there has to be an element there for somebody to be able to do things that's outside of the evidence to get somewhere that no one's ever been before. And I think that's a fun place to be as an osteopath. That can be a good place to be as an osteopath. But obviously we don't want to do things that are just not being that can't be tested.
Yeah, I think I agree with all of that. I think
outcomes for me are important. This is where I come from. Patients always ask me, can I do this? Can I do that? I'm saying, look, if it gives you a result, I don't care if you do a rain dance. I don't have evidence that it works, but if it gets you a result that you want and you want to do it, I don't mind that you do it. And I guess that's where I'm coming from. You just want to help people, and I try and make sure that I'm trying to give the best evidence to help people. Sorry, the best advice to help people. And I hope that doesn't go against the evidence. I'm not somebody who's constantly looking at the evidence all the time, but it's just something that has to be there in your practice. You have to understand what's out there, especially in the musculoskeletal field. Like it's just you have to do it.
Yeah. I think the issue is when, I think patients are vulnerable people. Some are particularly vulnerable, and they're vulnerable to authority. They're vulnerable to the trappings that people have. And I've just seen too many instances of people who've wasted thousands of dollars on treatments where the treatments are based on unreliable tests that we know are unreliable, that have never been proven to be reliable or shown. They're always consistently unreliable, yet they're told this, that, and the other, and you just go, oh, that's still going on. So obviously it's still being taught, and people are still doing it, and they're still rolling those things out. And I think that's what's sad about it, is when patients are just given diagnoses and prescribed treatment plans based on things that just are noise, and then we know they're noise. And so I think there needs to be a progression away. I just think it's, well, what would you call it? If there's tests, for example, that are not reliable and therefore they're not valid, how do you feel about people continuing to use them and then tell people, here's what you've got because of this test?
Look, you have to, with regards to testing, I guess you need to have the context around what you're using the test for, right? And if you're using testing for just motion testing, as opposed to actually a standing flexion test is not going to give you a diagnosis. It's not reliable. It's not valid for back pain. It's not one of the things. But a standing flexion test might just tell you how far somebody can stand and flex. That's all you're after. I'm just interested if they can bend over and touch their toes. And then what do I see happening in their body when they're doing that? Now that comes back to what I see and what I observe, and then it goes back to my experience as a practitioner. And have I seen this particular pattern before? And then I can start to use that. But I'm in no way, I wouldn't go and tell a patient that, well, this test, because this has happened with this test, you have this condition, because it's just not reliable or valid for that. But do I still use it? Do I still ask people to bend over and touch their toes? Sure, I do. But it's telling me data that I know is not what's the word I'm looking for? It's not corrupt, or it's
Yeah,
not.
I mean, I think that's the case, right? A lot of tests are like, okay, what can we gather? There's testing lots of things like pain reproduction, for example.
Yeah.
Like full range of motion, which, by the way, when you're looking at that gross range of motion there, that is reliable. And so when you combine those two things together, if you're doing a standard flexion test because you think you can tell that there's a restriction at some inferior pole of the sacrum against the ilium, and that's what you're doing, then that stuff's not reliable and not valid. And so when people then get labeled with those types of things, that's what if they want to do it, that's what they do. But I wouldn't be recommending people go and have that type of that type of thing.
Yeah, I think a lot of it's in, like I said, the framing of it. Like, I'm not telling a patient. For me, this is what I teach I said, to have an effective diagnosis, you need to have two things, which is a primary diagnosis and the secondary. And for me, the whole, the hips doing this, the lumbars are doing that, the knees doing this, that's a secondary diagnosis. That's just movement, right? And we could debate that between practitioners, and I feel that comes back down to the individual skill and experience and exposure of the practitioner. Some practitioners will get it right and some won't. Just like when a cardiologist can lay down a patient, do some tests that they've developed, and they can kind of have an idea of what's going on versus an idea of what may not be going on, but they're not the tests that would define cardiac arrest or something like that. Now, a primary diagnosis would have to indicate the tissue that's sourcing the pain, and that would require pain reproduction. And it would have to indicate for me the stage of healing it's in. And once I understand those two things, I can then give them a primary diagnosis. And putting the primary and the secondary together really gives me an effective diagnosis. And then I can go about and develop a plan to kind of start to unwind that. That's how I approach things. So I don't tell people that, hey, your hip being, I hear that a lot. People say, oh, I went and saw somebody and they told me my sacrum or my innominates were twisted. I'm like, look, that's fine. That's what they found, but that's not, I can't tell you that that's what's actually causing your pain or that's what's sourcing your pain. And so you have to make that distinction to patients. Otherwise, it's just, you're kind of selling snake oil. So, all right, well, moving forward from that, is there anything you want to add to that? Am I saying something that you want to push back against?
No, it's all good.
So I want to discuss with you, moving forward, you've mentioned osteopathy and some of the challenges. Where do you see some of the opportunities for us? Is it kind of overcoming those challenges? Is that where you think there's opportunity for osteopathy? Like, if I'm an osteopath and I'm, where do you think there's some opportunities there of being a good osteopath? What can they do to kind of have a great impact? Or do you think we're lost? Do you think the profession is just too, are we too kind of convoluted in our own kind of biases that it needs just some time to kind of get over that?
Look, I'm not in it enough to know. I get to see things pop up,
right?
And some of the things I see pop up are, like, here's a new research paper that's been published, and I'll maybe I know the supervisor, or it's someone I heard of, or it's an interesting topic.
Let me reframe it for you. Sorry, who would you ever see an osteopath, and what kind of osteopath would Nic Lucas see?
Would I see an osteopath? I haven't
in a while. I know you haven't in a while.
Yeah, I haven't gone and had manual therapy since 2009.
Right.
Myself. Right.
Okay.
Now, the caveat with that is that have I had injuries or have I had things go wrong? Yeah, but I know how to self-manage, so I haven't needed to, right? And what have I done? I've used a pain mechanisms approach to diagnosis, right? To move through it, and also understanding a lot about pain is also not catastrophizing about pain, not letting it stop me from moving, and trying to understand what it was that I did. So I've applied the same principles that I ended up applying to most of the patients I consulted to myself. So what I've advocated, well, I wouldn't even say advocated, what I've stood for a long time, and I've made sure to say, I'm going down this path, and I don't invite anyone else to come with me. Like, you all stay doing what you're doing, and that's fine, right? But I'm going to go this way, and this way is active care.
Yep.
Right? It is understanding what I'm doing with my body that is leading to problems, if indeed I am doing something, right? And that involves investigation, and then finding an active way for me, and therefore if I was going to be advising someone else, how to do that. Now, earlier on, when I was still registered and still insured, and I began consulting, not in osteopathy at all, I'd have people on the other side of the world who I'd been consulting with something else, and they'd have looked me up and they've gone, oh, I see that you used to do this. I'm considering getting this, or I'm considering going that. What do you think about that? And I'd go, you know, and they'd say, no, please weigh in. Anyway, so the number of people that I was able to continue to help over, back then it was GoToWebinar, it wasn't Zoom, that wasn't around then, right? But the number of people who had gone from, procedures they were going to have, a lot of based in the US. I mean, they are very invasive over there. They're ready to go and try anything.
Yeah.
Just through simple advice. Anyway, so would I go to an osteopath? I haven't felt the need to as of yet.
Okay.
Yeah.
All right. Look, I want to discuss success with you. This is obviously, we're called Success in Practice. So I want to kind of dive into that topic. One of the things I want to just note before I ask the question, there's a thought out there that achieving the goal is somehow less important than the journey, and that success shouldn't be defined by what you actually achieve. So I want to explore that for a minute, because I think we're getting a little bit carried away with making excuses for failure and moving goalposts. I take the example of, for example, I'm a big football fan. I've watched all the World Cups. I remember going to Brazil and watching the World Cup in 2014, cheering on for Lionel Messi in Argentina to win, and they made it to the final and lost. And then in 2022, they finally won. And if you ask any person, they would say that the 2022 campaign was a success and the 2014 campaign was a failure. Now, can you learn from failing? 100%. That's not the debate. But I think we're throwing out the whole concept of actually winning to kind of say, well, hey, the journey is really important. Let's forget about the goal. Can you comment on that? Because I'm kind of hearing things out there saying, it doesn't really matter if you achieve what you set out to achieve, as long as you do the work. Hello, everyone. Just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes. So for more information, please see the show notes. Now, enjoy, and back to the show.
That comes from an operating system that's been in our culture for a long time, centuries, and it's a right-wrong operating system, right? So we frame everything as being either right or wrong, including ourselves. So we all are addicted to being right, and we don't like being wrong. And so therefore, that's why people are afraid of failure, or using the term failure. And the reason they do that is because they inappropriately merge failure of a skill, which has got nothing to do with them as a person, with them as a person. So from the time of kids at school, if they get the answer wrong, it's not just the question that they didn't know how to add up properly yet because they haven't learnt it. They then internalize that and go, oh, that reflects on me personally, right? And then that gets fueled too, because people will see them or they don't get as much reward at home or whatever it is. And so there's this whole culture of right and wrong. And if you look at all the debates, you look at the way politics runs, you look at the comments there are on thing, look at COVID, for example, and the way that was so divisive. Why is it divisive? Right and wrong. Now, it's not that that's an ineffective mental framework to use, but it's only one framework to use. And another framework to use entirely is to do away with right and wrong thinking entirely, and use, and this is a mentor of mine who taught me this, he's a cognitive scientist. He said, use a different operating system, which is, here's the current version of the situation, and we can all imagine a better version of the situation. All of us, there's always a better version we can imagine. Yeah. And in doing that mental framework, there is no room to be going blame, right, wrong, anything like that. It's just like, here we are. This is what happened. And that's where we want to be. And so that way you can say, what does failure mean? In my mind, it means I had a goal to achieve. I didn't reach the goal. I call that failure. But I do not internalize that. I do not let that squash my confidence at all. It's not to do with me as a person. I haven't become less of a person. I'm not a failure as a person. It just so whatever happened at that time, I wasn't successful. And the duality of that, or the opposite of that, is I failed. Now, if people need to reframe that word and say, oh, well, you know, it's not failure. Again, my question is, why do they need to do that? And often it's because they associate the word failure with some deficit of themselves, and they don't want to do that. But you don't need to see failure as a deficit of yourself at all. You can still just call it what it is. And so I think, that's where I think that comes from. And I find it very useful with clients I have to help them reframe everything away from right and wrong, and have them just enter into the much more peaceful mental framework of current version, better version. What do we got to do to get there? And then that's where all the focus goes, right?
Yeah, look, there's nothing wrong with failure. Like, you know, it's actually probably a better teaching tool than success, some people would argue.
Well, I'm here and I get to do what I do because I've failed more times than a lot of other people probably have. You try more times, you're going to fail more times on average. No one wins all the time. So you have more shots at goal. You're going to miss a lot more shots at goal, but you'll also get more shots in the goal.
Mate, if I speak to Rhoda, I'm sure she'll tell me that you failed 10 times before you met her. So, you know, finally succeeded. Right. So, all right. Well, look, I think that's a good place to end the podcast for the public viewers, the people who are listening in. What I will do, though, is continue this conversation with Nic for my Success in Practice students. So for everyone, thank you, Nic. Thank you for joining us. And I hope we can do part 2 somewhere down the future where we can kind of explore some more of your thoughts around business and so forth. So thank you again, Nic.
Pleasure.